all for being here today. I'm so excited to have this wonderful cast, this panel. I'm going to have everybody introduce themselves. Tell me a little bit of yourself, where you're working, and also what made you want to treat breast cancer patients. We'll start with Joseph.
My name is Joseph Panoff. I am a radiation oncologist. I was trained at University of Miami, and then I stayed on as faculty. I used to treat pediatrics and breast cancer. And now I'm at Miami Cancer Institute, and I exclusively treat breast cancer. I chose the specialty because it has the greatest patients, and I have a family history of breast cancer, and so it's particularly meaningful to me.
Star.
Hi, I'm Star Mountainer. I'm a breast surgical oncologist. I work at the Miami Cancer Institute. I trained at the University of Miami for undergrad and medical school, and then I was at Weill Cornell at New York Presbyterian Hospital in New York for residency and Sloan Kettering for fellowship. Moved back down in 2015 when MCI was opening and have been there ever since. I chose to go into breast surgical oncology. I agree with Joe. We have the best patient population. It's truly a very rewarding field. You get to help a lot of women, and because we've gotten so good at detecting cancer early in the breast, patients do really well for the most part. And so it's very rewarding to be able to help these patients, to be able to physically cut out a tumor and follow them 6 months, a year, 5 years later, and seeing them do really well. And you get to meet their families, you really get to know them very intimately. And so I've been very happy with the field that I've chosen. I love my job. I think it's one of the best jobs, and I'm happy to be part of this discussion today. You know, things like this in terms of research for breast is what keeps moving the field forward and what keeps it interesting.
Nice. Reshma?
So I'm Reshma Matani. I am at the Miami Cancer Institute as well, Chief of Breast Medical Oncology. I actually did my training in New York as well at St. Vincent's Medical Center. And I moved down to Florida, and I was at the University of Miami for many years, 11 years, where I led the breast cancer program there for the last few years. What made me go into breast cancer, I guess I'm just kind of piling on and echoing the comments of Joe and Star. I think our patients are really what drive us, inspire us. Breast cancer patients are a particularly engaged group of women. Right, so women tend to be the caretakers in their family. They tend to take care of everyone and navigate through a lot of tough decisions. And I'm always challenged by patients in terms of questions that they ask. They ask great questions. They're really involved in their care. And like Star mentioned, it's really rewarding to see the progress that we've made for our patients, and we have the opportunity to longitudinally follow these patients, and they sort of become like family, and it's such a great experience and a privilege.
Yeah. I'll say about myself, I'm Yolanda Bryce. I'm an interventional radiologist. I also do a little bit of breast imaging. I work at Memorial Sloan Kettering Cancer Center. I did my breast imaging training there. I did my IR training at Miami Cardiac and Vascular Institute. And the intersection of both my fields ended up with breast cancer, breast imaging and IR. And so I pioneered the program of breast cryoablation at our institution, and which has grown and is doing well. I also do treat metastatic breast cancer with local regional therapy, lung, liver mostly, doing ablation and radioembolization. So that's what, and why did I choose it? I think it's just, it ended up being the two areas that I studied, and because of mentorship, it's where I came. A big factor of that was Elizabeth Morris, who has since moved on as chair somewhere else, but she was very instrumental in meshing those two paths for me. All right, so we're gonna first concentrate on primary breast cancer, and I think that's where we'll spend most of our time, and then we will talk a little bit about metastatic breast cancer. Okay, so these are very broad questions, but Star, could you tell me about your general approach when you meet a breast cancer patient?
Sure. As the breast surgical oncologist, I'm oftentimes the first physician that the patient will see after they've been diagnosed with breast cancer. So understandably, they come in extremely worried and scared and stressed with this new diagnosis. And so the first thing I do, number one, is review their case, actually look at all the imaging, the pathology. We have everything reviewed in-house to have a clear understanding of what it is that I'm walking into. Every patient will be different, and when you start speaking to them, the conversation may go into a different direction, but I like to be mentally prepared as to what options I'm going to discuss with the patient. You know, whether they may need neoadjuvant chemotherapy versus upfront surgery, whether I know that they definitely will need a mastectomy, or if they're a good candidate for lumpectomy. And then the other thing is reassurance, telling them that they're going to be okay, because in a vast majority of cases that is true. And I think that when patients hear that for the first time, it really helps calm them. If patients walk out of my office more calm and more reassured than when they walked in, then I know that I did my job correctly. And so that's always my goal, to make them feel more comfortable than when they came in.
So we did talk a little bit beforehand about poor surgical candidates. What to you is a poor surgical candidate?
So I think a patient can be a poor surgical candidate either because they are not healthy enough to undergo surgery, although their tumor is resectable, versus whether their tumor is not resectable. They may be a healthy patient, but they may have extremely bulky disease that is not a surgical candidate in that perspective. And so you have to look at the two different types of poor surgical candidates, and usually they'll be on two ends of the spectrum in terms of age. And so some of our older patients may have small tumors, but they may just not be healthy enough to undergo anesthesia. Luckily for small tumors, we can get by with MAC anesthesia and don't need general. So I would say it's rare that a patient is truly unhealthy enough to undergo breast conserving surgery. And so that's a very small minority of patients. Some of our younger patients that present, unfortunately, with very late stage disease, or it's just been ignored for several years, they may come in with disease that's matted lymph nodes, you know, ulcerated through the skin. And I've seen a handful of cases like that as well, where really, unfortunately, me operating on that patient is not going to do them any favors, because we're not going to be able to get clear margins, and the tumor's going to come right back. In those cases, we really try to lean heavily on our medical oncology and radiation oncology colleagues to come up with kind of a multidisciplinary plan to be able to treat that patient, and then hopefully one day get them to surgery.
And how do you deal with a patient who refuses surgery?
Luckily, that doesn't happen too often. Those are very challenging cases. I think that I try to get to the root as to why they're refusing surgery. Is it a fear over anesthesia? Is it a fear of, you know, what's to come after surgery? I think that I always will say that if they want to seek a second opinion, that I would encourage that and make sure that they're going to a colleague that would offer them something similar to what I would offer them in terms of the standard of care. But reassuring them that if they were to seek surgical options, that this is a highly curable disease, and that they're at a point where we know, you know, how to treat this, and if we wait on it, their options are going to be less and less. And so fortunately, I don't have to have that conversation often, because it is a tough one.
Yeah, it's very tough, and I never know what to do with these patients, because, as I said, I do cryoablation of the breast, but I really want to have a reason why patients are refusing surgery, because I do want them to have gold standard of care. But sometimes they just don't have a reason, and I don't know what to address. But yeah,
I run into that much more often as a medical oncologist.
I believe you.
I think, you know, when patients come in, as Star mentioned, they're understandably very overwhelmed, and a lot of my initial conversations surround just explaining to them what different members of the team do, and that no single person is sort of driving the ship, but we're working together as a team, and having them get a better understanding of what part each of us play. And I think from the surgical perspective, you know, I think that's the most intuitive for patients, because they recognize they have a tumor and it needs to come out. And so I think that from my perspective, when I start talking about the therapies that I offer, that's where you start to sense, you know, people sitting back in their seat a little bit and getting a little nervous, because it's scary, and they're worried about side effects. Nobody comes in asking for chemotherapy or asking for any of our other treatments or excited that they need them. Cancer diagnosis never comes at a good time. It is always disruptive of whatever else is going on in their life, and it's a tough situation.
It is a tough. Okay, so let's see. I wanted to ask you something else, Reshma, specifically for you. There are some breast cancers that I think are more challenging than others. What would you think? What would you say constitutes a challenging breast cancer to treat?
Yeah, I think that's a broad question, but it also gets to the heart of the fact that all breast cancers are not the same, right? And breast cancer is not just one disease.
Yeah, very heterogeneous.
Absolutely. And as we are gaining more knowledge about our therapies that we can offer patients, individualizing and personalizing those therapies is a challenge, because sometimes we see patients that come in, for example, with a lobular breast cancer that is very large but and has gone to multiple lymph nodes, and the standard would be to offer chemotherapy, but it's a highly estrogen receptor positive tumor, grade 1. They come back with a low genomic score, and as a medical oncologist, our gut instinct tells us that this is not going to be a chemosensitive tumor, yet we don't have the data to forego chemotherapy in those situations where the tumor is large, there are multiple positive nodes. There are other clinical scenarios, like now we're dealing with this question of premenopausal patients with a low genomic risk, and whether or not to offer them ovarian suppression and endocrine therapy in lieu of chemotherapy, understanding that that's an unanswered question. So I think as we have more options for our treatment and trying to balance those against the side effects, individualizing our treatments for the patient in front of us sometimes becomes a challenge.
Mm-hmm. Yeah. And how do you treat patients that are not surgical candidates or are poor surgical candidates?
So I would always make that decision, obviously, in conjunction with my surgical colleagues. And if we have a primary breast cancer patient who is not a surgical candidate, the hope is that with some combination of systemic therapies that we can convert them to a surgical candidate. We tend to not utilize neoadjuvant hormonal therapy very much here in the US. It's used quite a bit in Europe. The goal there is really to have the patient have an understanding of what that time course might look like and set expectations. Mm-hmm. It can take several months, and perhaps a patient may convert to having an operable tumor.
Yeah.
So that's the hope.
What about if the patient is not a surgical candidate due to comorbidities?
Well, I would wonder if those same comorbidities that don't make them a surgical candidate would impact my choice of systemic therapies. Mm-hmm, mm-hmm. Fortunately, I think knowing that 2/3 of all breast cancers are hormonally driven, it's the rare patient that can't take at least hormonal therapy. We don't run into patients that have the inability to tolerate all of our treatments. It's just whether they're willing to take the therapies. That's a entirely different conversation.
Yeah. A lot of these women, even with hormonal therapy, strong ER positive disease, they eventually progress on hormone therapy.
In the metastatic setting you're referring to?
In the primary even.
Well, I think we've done a lot in terms of identifying patients based on their genomic risk that are going to receive a benefit from chemotherapy and endocrine therapy. And as Star mentioned, many of our early stage patients are cured with a combination of surgery, radiation, and our adjuvant systemic therapies. Selecting out those patients that are higher risk and escalating treatments that will further reduce their risk. Like now we have adjuvant abemaciclib, we have adjuvant PARP inhibitors available. I think we're making steady inroads into decreasing that risk, but to your point, there are patients that will still recur with early stage breast cancer, and in that setting, our systemic therapies are going to be really important in the metastatic setting.
Yeah. I agree. So, Joe. Okay. So let's talk a little bit about using radiation for a more definitive treatment of primary breast cancer in a patient that is not a surgical candidate. So there has been some studies, most of them older, but there was one that I saw recently published by Jonathan Lischalk from Georgetown, and they were looking at using radiation as a definitive treatment for an elderly population. And they, from what I gather, is it depends on where the tumor is in the breast. But any thoughts on using radiation in a non-surgical population?
Yeah. Again, I echo what Reshma and Star both said about it being a rare case. And, it's very infrequent. I would say that just talking about Georgetown, they invented one of our treatment platforms, which is called CyberKnife, that a lot of people have heard of. So they actually have 2 CyberKnives there, at least they used to. And so if I had to guess, that trial utilized CyberKnife to deliver a very high dose of radiation to a conformal area in a few fractions, which is called SBRT, or stereotactic body radiotherapy. And you could do that. I know that there's some very few trials looking at it. What's really more common, and there's many clinical trials right now that are looking at, is pre-op. So treating with SBRT in the preoperative setting to either downstage the tumor, or there's a lot of benefits. There's a lot of theoretical benefits to preoperative radiation, and even at what we call ablative doses. So high dose per fraction and few fractions. And you have to really, the thinking there is that you have to have the technology that allows you to safely treat a very conformal area while sparing the surrounding tissue. But I think that we're a long way away from seeing that routinely used because we don't have good long-term data on the toxicity.
Yeah, if I recall what I read of the paper, they were saying that a lot of it has to do, they were able to get enough, the high enough dose to the tumor, but sometimes if it was too close to the skin or the chest wall, there was a problem.
Right, exactly.
Yeah,
those are going to be your dose-limiting tissues
I see.
treating something like that.
All right. So there's also, I guess I'm trying to push a little bit the envelope in exploring the space of in the very few select patients, the omission of surgery. I know that there's MD Anderson is doing a lot of work in trying to look at patients that have neoadjuvant chemotherapy that are HER2 positive or triple negative breast cancer, because we know that when that population, they get neoadjuvant chemotherapy, their cancers tend to shrink like this, whereas ER positive, they shrink, but they more shrink like this. People can record what I'm saying with my hands, but so there is an idea that maybe with a certain population, the HER2 positive and triple negative breast cancer, that the cancer shrinks and may disappear completely if those patients then after chemotherapy can go on straight to radiation.
Right.
So the PI on that study is Henry Quer, or I maybe pronounced it, and I apologize. He's actually a breast surgeon, and
Is that a Mayo trial?
No, it's at MD Anderson.
But it's at 7 sites. I don't know if it's at Mayo.
Yeah, there's a Mayo.
Okay.
Yeah.
It's at 7 different sites.
I see. So he did a lot of prelim work. Now it's a phase 2 trial. Any thoughts on that approach?
I think it's very exciting, and I think you need to be careful how this gets portrayed to the public, because a lot of times people will hear that and say, oh wait, I don't need surgery anymore, and obviously those results cannot be generalized to the wide population at this point, and we'll need more randomized clinical trials with long-term follow-up. I think they have just over 2 years of follow-up, which is excellent. And in the group of 30-something patients that they said responded to the neoadjuvant chemotherapy completely based on vacuum-assisted core biopsy after treatment, those patients have not yet locally recurred. And so I think that this is pushing the envelope, but in a really good way, and that they're calling these patients basically exceptional responders. And that there is going to be this select group of patients that have PCRs that may not require surgical excision in the future. But my fear is, what about DCIS? Because these patients, obviously the high-grade invasive ductal cancer that's triple negative or HER2 positive responds really well to targeted treatment and to chemotherapy, but the DCIS does not. And I've had patients that have a complete pathologic response with their invasive cancer, but have scattered areas of DCIS, and maybe not even huge areas of it, but scattered. And so at some point in the future, I have a feeling that some of these patients with longer-term follow-up, on mammogram, they may start seeing a trickle of microcalcifications in that area again, because I just saw a patient who were following stage 4, HER2 positive, that's getting neoadjuvant chemo, that was doing great for a few years, and now her mammogram is showing calcifications that are biopsy-proven DCIS in the same tumor bed. And so I think that we're not quite there yet to say that these patients absolutely won't need surgery in the future, but it is an exciting notion that potentially we can do away with surgery on some of these exceptional responders, and maybe with the addition of radiation to the treatment platform, they may not recur in the future, and that would be amazing. But I think, even the PI of the study will say that this needs to be looked at with much longer follow-up in much larger populations before we can generalize the results.
Because with the standard of care, which is, surgery, radiation, and as needed, it's systemic therapy. We're talking about the recurrence rate. We're measuring it for breast cancer like 5-10 years, a long time. So 10 years, right? 10, yeah. So because these women, they're essentially cured. So it is true that the 26.4 median follow-up with no recurrence is still kind of short, very.
But it's exciting that there's not one patient in that group that's recurred.
That is recurred.
So
I agree.
The other aspect of that, from the systemic therapy standpoint, I would say is that we know that achieving a PCR is prognostic, right?
Yes.
And anything you can give to the patient to get them to PCR is something that obviously everyone's very interested in. But my concern would be, are we adequately with a core biopsy really ensuring that we're not dealing with micrometastatic disease that's being missed? Because we know that imaging is only so sensitive. You have patients that on exam and by imaging look like they have a PCR, and then they go to surgery and there's residual disease.
Microscopic, a millimeter,
if you look at the trials in the HER2 positive space, like the Catherine trial, even patients that had very minimal T1A residual disease benefited from the use of adjuvant TDM1 in that setting. 50% hazard ratio was 0.5, so 50% risk reduction, right? Yeah. And so tailoring our therapies on the other side of surgery based on what that response is really important. And if we're skipping the surgical part of it, are we adequately assessing what their response really is? And are we perhaps missing the opportunity to escalate their therapy on the other side?
Yep. So the long-term follow-up will be key on this population.
They're doing 12 vacuum-assisted core biopsies with a 9-gauge needle, so it's basically a mini lumpectomy.
Okay.
But still, I can, as a surgeon, when I go in there and do a lumpectomy and then do margins, every once in a while you'll get this surprising pathology, like where the main lumpectomy specimen has just scarring.
Right.
And then in some of the edges, you'll have like a 1 millimeter focus of microinvasive disease with some DCIS or something, and that could be something that could be missed even with 12 core biopsies. So I think another 2 years, 3 years of follow-up of that study will be really interesting to see.
Yeah. The targeting for radiation also in the setting of having a complete response is challenging. Right? What do you treat there? Because we need a target.
I guess you have the core. I don't know. You may have
you would have to put clips,
or the hematoma from the 12 cores going in. Maybe there's
I think they're targeting the clip, because when they do the biopsy, they're replacing the clip, and I think that's what is being targeted.
And do you know how many clips?
But I think one.
See, that's a very small target.
But I think it's whole. So you would do whole breast radiation probably in this scenario, and then typically you boost. Where the tumor is. So something like this, what do you think?
Well, for us, the paradigm for us is kind of the opposite, which is we've tried to de-escalate everything, right? We treat completely different now than we did 10 years ago. In the early stage breast cancer setting, we used to do, most places, whole breast 25 treatments and then a 5 treatment boost, more or less. Now in the whole breast setting, we do 16 treatments and plus or minus so a 4 fraction boost. And then even more so, we've now moved towards external beam partial breast. We used to really mostly do brachytherapy partial breast. Now we do a lot of external beam partial breast, which is 5 fractions daily. And I mean, the toxicity profile is almost non-existent with that. So people just do so well.
So explain that again,
Yeah.
the regimen that now you
For whole breast or
Yeah.
for partial? For whole breast now, most places there's some data, there were large randomized controlled trials from Canada and UK that compared 15 or 16 fraction regimen with the standard fractionation, which was around 25 plus
Yeah.
boost, both
Yeah.
plus boost. And they, at 10 years, found that they were equivalent in overall survival and local control and recurrence. So I don't know of any places, there's probably still some private practice places, but most large centers treat, the great majority treat with what we call hypofractionation, which is 16 fractions. Some places do 15 or 16 fractions
Yeah.
whole breast. And then for very favorable, even in the early breast setting, very favorable early breast cancer patients get 5 fraction partial breast. You can do that.
I see. And the recurrence rate with the partial is the same?
Right. So then there was a large Italian trial called the Florence trial that compared partial breast, although it was partial breast 5 fractions, with whole breast, the more conventional 25 fractions, and they found at 10 years equivalent local control, recurrence, and overall survival, which was less than 3% the recurrence at 10 years. And this is carefully selected
Yeah.
patients.
Yeah.
Right, and tumor size, grade, margin status,
I
receptor.
always feel nervous with that partial breast radiation.
There's good
But I
data.
guess
There's great data on it.
now.
Yeah, absolutely.
That's awesome.
And large meta-analyses. Now,
Yeah.
the caveat with that is, if you pool all of the different partial breast techniques,
Yeah.
there's one that's intraoperative therapy, IORT, which was with electrons and photons, 2 different types. And it seems like there's a higher recurrence rate with that because most of the hypothesis being in multiple meta-analyses that the planning is not as sophisticated.
I see.
It doesn't have CT-based planning with that.
I see.
So you're missing maybe.
You're missing something.
But
Yeah.
what we do is IMRT based, which stands for intensity modulated radiation. It's very sophisticated planning. But what I was saying, to get back to a tumor that you were treating, is if you have a clip, what margin do you give it? Because you need to
Yeah.
give it a clinical target volume margin for microscopic spread. And then what margin would you give for motion? And there's a lot of questions.
Right.
But it's very exciting. I agree.
Yeah, we'll have to look a little closer into what it's an ongoing trial, so
Right,
we'll
and
have
I
to
don't-
see
I-
what
I'm not
they have.
familiar.
They've done 31 patients, I think, but there's more, obviously
Out of
more
out of
patients.
50.
50,
So
yeah, 50
what
will be there.
happened with the core biopsies? 20. So did selected out because they still had residual disease. So those patients went on to surgery, and 30 did not.
I thought they
and-
were accruing till 50, or they're done accruing.
I don't know, but I know that there were patients that
Yes.
still had disease,
Yes.
and so there's been 30 that are disease-free
right.
that have gone
That-
on to
that
no
is
surgery
correct.
and are still disease-free.
Yeah, that is correct. Okay. There is also a little more, there's also work being done in the space of, I guess low-risk breast cancers is the best way to put it. There was firstly a landmark study, it was called ICASOG 1072, or Z1072. That was led by Rashi Simmons at Cornell, also a breast surgeon. And what she did, it was a pilot study. They ended up doing 87 breast cancers that they did cryoablation on, and then sent them on to surgery to see the success of ablation. And what they saw is there were certain tumors that didn't work very well for cryoablation with the technique that they utilized, which since then, this is an older study, things have probably changed, but at that time, the study they did, they saw with certainty, like with very small breast cancers, 1 centimeter or smaller, these patients had 100% ablation. So there was that, and that had the benefit of going to surgery so that they could explore the area. And then there's two other studies, the Frost study and the IceCure3 study, that they're looking at patients that have tumors 1.5 centimeter or smaller. They're very, very strongly ER positive, grade 1, women older than 50. So we're talking about a very
Carefully
low
selected
risk,
patients, yeah.
very
It's like
selective
the partial breast
population.
patient
Exactly.
population.
And so what they have seen, at least the IceCure3 published their interim 3-year data, and they saw a 2% recurrence rate in that population using imaging, because these patients are not going on to surgery.
They go on to standard hormonal therapy.
They're going
though.
through hormonal therapy
And they're doing radiation.
and radiation.
Whole breast, they're doing whole breast.
Whole breast radiation. So they have to agree in order to go on the trial that they have to agree to hormonal therapy, they have to agree to radiation. Any thoughts about something like this? This is trying to push the envelope again, because here in the U.S., at least because we have population-based screening, there's some of the cancers that we're finding are very small. So wondering any thoughts on where this might end up.
So these are patients who are surgical candidates, but instead of doing surgery, you're doing cryoablation.
Yes.
Yeah, I mean, again, I think that you would need, it sounds promising, right? That population, they just do so well.
Yeah.
And that number is the same as, very similar to lumpectomy and then, focused partial breast radiation. Like, you need large numbers of patients,
Yeah.
and you need it to be randomized, and you need long-term outcome to see.
I think that's the key. I think the longer we can follow these women and see actually what the recurrence rate is will be key.
And also, you need experienced breast radiologists that are reading these films, because I'm sure that what the field looks like after a tumor has been cryoablated on mammogram, ultrasound, and MRI, you need to know what to look for in terms of recurrence, because it could blur the picture if you have like an icicle in the middle of the breast that obviously dissipates over time. But, will it take 2 years versus 5 years to see if something small is regenerating in that area? Especially while they're on endocrine therapy. So I think it makes sense that these patients are doing well up until this point. But, it would be bad news if, 5, 6, 7 years out, you start getting microscopic disease back in the area and can't detect it on imaging because of scar tissue in the area. So I think that a lumpectomy cavity may look very different than what a cryoablation cavity looks like. I'm not sure, because I haven't seen enough of them on imaging, but you need experienced breast radiologists to know what to look for. And so I would say you have to once again be very careful about how this is portrayed to the public, because you'll have these random, especially in Miami maybe, interventional radiology suites opening up, offering cryoablation to the public instead of surgery, and there will be a lot of women that are seeking that out, and then they're not being followed up in a major cancer institute, and who knows what their recurrence risk truly is in the future. So it has to be rolled out very carefully and in a very select group of patients.
The only other thing I would say is also one, in the younger than 70 population, because you said it was older than 50.
50.
Lymph
Older than
nodes.
50, yeah.
Right, there's no...
They're actually doing, for that trial, sentinel lymph nodes.
So they're taking
Yeah,
them
so
slower
they're
anyway?
still taking them to surgery.
And what happens if they have a positive lymph node? They're off the trial? Or?
I'm not sure about that.
Okay.
I'm not sure.
And then again, just to bring in the systemic therapy view, I mean, as we select patients for a strategy like this, and the expectation is that hormonal therapy is going to be on board.
Yes.
That's always the expectation when we
Yes.
start. It's unfortunately not always the reality, because patients can say that they are going to take hormonal therapy and with best intentions go on the treatment, but we know these therapies are tough to tolerate, and adherence and compliance with hormonal therapy can be poor. Our drugs cause a lot of side effects that really impact quality of life, and many women either discontinue or stop taking the medication. They don't tell their physician, or they have to take breaks, and how that's going to impact outcomes is also something that would have to be taken into account.
That's a very good point. Again, shifting a little bit in omission of surgery, but in a non-surgical population, there hasn't been so much data on that. There was a small trial in 2009 by Littrop, and he looked at cancers up to almost 6 centimeters, and he saw that if you put multiple probes, he got a good result. I guess this is just kind of an illustration of how my practice is. Where I work, again, I treat patients that are non-surgical candidates or poor surgical candidates as determined by a breast surgeon. And I always tell everyone that surgical candidacy is only determined by the breast surgeon. If they tell me the patient is a poor surgical or no surgical candidate, they send me the patient, and that's the population that I treat. And I do see that a lot of patients, when they're not able, they can tolerate very well the cryoablation because they're awake, they're talking to me and so forth, and they do very well. And I do push the envelope a lot when the patient is not a surgical candidate but has very large tumors. I do push the envelope, and they tend to do well. I do try to. I offer everybody a referral to medical oncology and radiation oncology because I think the synergistic effect is always better. Again, this is data that we need to publish and look at long-term to see the long-term benefit. But I do, just anecdotally in my practice, I do see that when the patients say yes to the combination of therapies, they do better. I do find, though, I agree with you about the long-term use of the hormone therapy. They don't stick to it. And
No.
a lot of the women,
There's data that shows a 50%
yeah,
attrition.
they don't
Yeah.
stick to it. And I think also the population I deal with, they're older women. They tend to be very stubborn and they're set in their ways. So they might try. They're like, oh, no, last night I had weird dreams. I don't want to. And I'm just like, well, I don't know if the dreams is related, but it's true. They don't stick a lot to it. I do want to address a little bit about the imaging after cryoablation. And I think I've been doing it long enough that I haven't had many recurrences, thank goodness, but I have had some. And recurrence actually looks like recurrence. It looks like cancer that came back. It doesn't look like you're not sure, like, what is this thing? It actually just looks like a cancer that just came back.
How long does it take the cryoablation cavity for it to look kind of like normal breast tissue again on a
Really
mammogram?
it never really does. It looks like fat necrosis. It
Like
looks
big? Like a big...
Depends on
Yeah.
so it depends if the tumor I treated is small, like 2 centimeters, obviously the area of fat necrosis won't be too large. If I treat it like a 5 centimeter, then it's going to be large.
Is it fat necrosis? Is it?
It looks like fat necrosis, and actually there was one time that the patient had some enhancement, so we biopsied it,
Yeah.
and it ended up just being fat
Fat
necrosis.
And is this something you follow on MR also? Is it a sensitive tool for it?
So in my practice, I do mammogram and ultrasound at least, but I do try to do some kind of enhancement. So it might be contrast enhanced mammogram or contrast enhanced MRI. My population, again, with the women that I treat, a lot of them have pacemakers or don't want to tolerate the MRI, so I tend to use a lot of contrast enhanced mammo, which I don't know if they have that at MCI, but hopefully they.
We don't yet,
But we
but
will
It's
soon.
an
yeah,
amazing modality
it.
that I
UM has it, yeah.
I think you will love it once you start it.
Yeah, I've seen it.
Yeah, the
And we have
women-
patients that bring their discs in from the outside with
Yeah.
it.
The women obviously prefer it a lot more than,
Then, yeah,
than the MR.
an MR is not fun.
Yeah. Okay, so what do you think would constitute a good trial, multidisciplinary trial, to try to determine the select group of patients that could forego surgery? What would be that? What do you think is that clinical design? Clinical trial
Are you
design.
saying patients who are not surgical candidates, or this
Let's
is a
talk
surrogacy?
Let's talk about a population of patients, because I think patients that can't go to surgery.
What patients who are surgical candidates don't need surgery, is what you're saying.
Yes. So right. So if we look at patients who are not surgical candidates, that's
Yeah.
to me that's an easy group, right? They don't have another option. So, but in patients that have the option, they have
Yeah.
the option for surgery,
Yeah, but they don't want surgery.
but they
want something different.
right.
Yeah.
What? How would you design that clinical trial to determine
And
which patient?
What is the
eligible?
modality that you're treating with? If it's not
Let's say
surgery.
let's say cryo because that's what I'm familiar
Yeah.
with.
Right. I mean, I'm not that familiar with how you would choose patients, with cryo. But I would say that you would want the most favorable population possible, which is going to be older than 70, ER positive, low-grade tumors.
Low genomic risk based
Yeah.
on
Yeah, for sure,
some
low
sort
genomic.
of diagnostic assay. I mean, I think a lot of this has been used based on size criteria, but
Yeah.
we know that that doesn't always equate to the biology of the disease. So some sort of assessment on a genomic assay that would tell us that this is a low-risk patient.
Yeah, I think size is being used because they want
The technicalities of the-
technicality.
yeah.
They want a good ablative zone,
Of course.
margins. I think that's why it's very hung up on size.
Yeah, so
but-
I guess that would have to be built into the inclusion criteria of the trial because the technical aspects of the modality you're using are going to mandate some restriction on size. But even within that, I think you have to be careful because, for example, a 1 centimeter triple negative patient, I don't know that I would, I mean,
Not a good
Yeah.
candidate.
a HER2 positive
Yeah,
patient,
yeah.
someone with a high-grade tumor where we really have very effective systemic therapies and the
right.
risk of recurrence is such that I don't know that you would want to go to a
Yeah,
modality that's not proven in that
that's not proven.
situation.
So you're talking about if you were to design a study, you're talking about a very low risk population, older women,
ER positive,
Small
HER2
tumors.
negative.
Small
Yeah.
tumors.
It may be interesting to go in a different direction and try it for DCIS in a small, like a 1 centimeter or
Yeah.
less confined area, and observe those patients afterward. I don't know,
So there is a trial that is being done now on cryo for DCIS. I'll tell you, I hate cryoing DCIS because I cannot tell that I've gotten all of it. It's not like with invasive. Yes, I
mass.
understand it's aggressive, but I can
You can
see
see
the
the mass.
borders. But with DCIS, I'm kind of just guessing because I'm not really seeing. I've done it under. I've done cryo, and then immediately taking them to the
So you have to do
MR
cryo
We
under
don't- we don't want you
ultrasound
to
guidance.
guess.
You can't do it under
You can
stereotactic
do it
guidance.
you can do it under MR.
Interesting.
But at the same time, not all of
DCIS,
DCIS
yeah.
enhances. And so I have done, and then it's also technically very difficult to do it, although I have done it. And I have also done where I put multiple hydrophilic clips in the DCIS and then did the cryo and then immediately did an MR afterwards. And it just looked so crazy. But I have done that. But I tell you, I don't. Cryoing DCIS is more challenging than cryoing tumor. But there is a study being done, but the area of DCIS is very, very small. And to be honest, maybe these women don't even need any therapy. There is the other trial that's being done where
Right,
they're
of
just
observation
observing
with endocrine
DCIS.
therapy.
Yeah. Anyways, I have a question because I've wondered this, and I think most trials are wondering this. What do you think we should do with the axilla in patients that are not undergoing surgery? Like either in the trial with the triple negative breast cancer and HER2/neu that they're going just radiation and chemo or systemic and radiation and they shrunk and they're not going to surgery. What do we do with these women?
Did those patients have positive lymph nodes? Were they biopsy proven?
I don't know about that. But let's talk about it in a scenario for a
The
clinical
neoadjuvant
trial.
trial has positive nodes, but
Yeah. I mean,
So and there's also the Z11 trial. I don't know if that.
there's a lot of
the
different,
Z11,
things you're
Yeah.
talking about. Yeah.
Yeah, we're talking about many things. I guess I'm just trying to explore the space
So again,
of omission
so
of
for
surgery.
from a radiation oncology perspective,
Yeah.
and I think a medical oncology perspective, the lymph nodes and what to do about them is a huge controversial area
Yes.
in the neoadjuvant
Yes.
setting. And there's a there was a randomized clinical trial, NSABP B51. I don't know if you've heard of that, but that closed to accrual about 2 years ago.
Okay.
And what that did was it randomized women who had a biopsy-proven node, and it could be any receptor status. So they were like patients who were, I would call intermediate risk, right? They couldn't have, I think, N2 disease. So it was N1 disease, and they had a biopsy-proven lymph node. They had neoadjuvant chemotherapy, and then if they had they were eligible if they had a complete response in the node. So the primary wasn't important, and so they had this complete response. Then they're randomized to, depending on the type of surgery, no radiation to the nodal basins, or radiation to the nodal basins. And if they had a mastectomy, they got no radiation at all. If they or comprehensive.
Yeah.
If they have a lumpectomy, then it's just whole breast versus whole breast and the nodal basins. So we're trying to, we want to remove nodal radiation in these patients because of the morbidity associated with it.
Yes.
I think that primary axillary recurrence is very low in terms of risk, and we've seen that from trials like Z11. But it's more important to help inform the clinical decision-making of the adjuvant medical and radiation treatment. And it's the reason why we're checking those nodes, not necessarily because we are so concerned that they're going to present with bulky axillary recurrence, which happens few and far between. But there are some cases specifically that I would worry about, which are lobular cancers, because I have had several patients, and they're just notoriously tricky, where the imaging can look completely normal in the nodes in terms of mammogram, ultrasound, MRI, even PET, and you are shocked to find 10 or 11 nodes that end up being positive in that axilla at the time of surgery. And so certain tumor profiles like lobulars can be very tricky. You don't want to miss a tumor like that. And you can see a lobular that's even small in size, strongly ER positive, HER2 negative, would probably fall into a category of, someone that might be a great candidate for cryoablation or, omission of sentinel node. And you have to be very selective of who you're going to omit that on, because especially with now, selective sentinel node biopsy in women over the age of 70 with ER positive tumors, I'm very selective about that, because if I see a healthy 80-year-old with a lobular tumor that, maybe she skipped 2 years of screening during the pandemic and then presented with a 1 centimeter lobular tumor, and I think I may feel something, in the axilla that could be reactive, I'm doing a sentinel node biopsy on some of those patients and finding metastatic disease. And so you have to be really carefully selective of who you're not going to check lymph nodes on. And I think that our medical oncology colleagues weigh heavily on what those nodes show. And radiation oncology, and that's the issue more so than the actual surgical removal of those nodes.
The estrogen PET scan offers
The Cerianna PET.
interesting, alternative.
That might be helpful in identifying occult disease, and there are investigations trying to see how it can be incorporated, especially in situations like lobular cancers. But getting back to Star's comment about nodal involvement and how it informs our adjuvant systemic therapy decisions, it's kind of remarkable to step back and remember years ago we were offering adjuvant chemotherapy to any woman who had a tumor over 1 centimeter in size, regardless of nodal status. So you could have a 1.1 centimeter lymph node negative tumor and you were getting chemotherapy. And now we've gotten to the point where we're omitting chemotherapy in lymph node positive disease, again, carefully selected patients who meet criteria or who would have met criteria for inclusion on trials like our Exponder. But recall, all of those data are in patients with N1 disease, right? So as much as we don't feel that patients that have lobular cancers grade 1 with 10 positive nodes, we feel that maybe chemotherapy may not be as beneficial, we still err on the side of offering it, because without any data to support foregoing chemotherapy in a situation where we have N2 disease, right?
I do wish we had better imaging modalities, and maybe the ER PET is the answer. I forgot about that. I think they just started at my institution.
There are studies going on at MSK looking at Cerianna PET.
Right.
It becomes real important when we talk about whether a patient should proceed with axillary nodal dissection versus radiation, just radiation.
Yeah.
Sometimes.
Yeah. It's interesting how you pointed out that it's not so much that you are afraid of the recurrence in the axilla, it's more to inform the different our
For us.
It's a surrogate for
oncology.
risk.
It's very
And
It's a
important
we
for
surrogate
us.
for
still
risk.
rely on stage for prognosis, right?
Right.
And stage is driven by, tumor size, nodal status, and now ERPR and HER2 status.
Yeah.
And so it's an integral part of that staging system. And if you just completely omit that, then you may be misstaging them.
Yes.
And we've made such good strides in, curing breast cancer for early stage disease that why risk taking a few steps
Agreed,
backward
yeah.
to avoid a sentinel node biopsy, which has
Yeah.
very little morbidity.
Very little morbidity. That's true. And I've honestly struggled because I've been asked to be on panels to design clinical trials about cryoablation. And my question is, well, what is the answer for the axilla? And we've talked about things of doing a biopsy, but again, the biopsies are just not the same. So most trials have just left the sentinel lymph node biopsy in. And I know the Z11 was very informative that with the positive lymph node, you don't necessarily need an axe dissection,
Right.
but you're right, it is still prognostic. Although the Z11, they did not radiate the positive lymph nodes. The patients that had, they did not.
The radiation was all over the place.
Well,
in
they
Z11.
weren't allowed to radiate the axilla.
They didn't do comprehensive radiation. They weren't supposed to. But so there's some papers that have come out and evaluated the fields that were used, and actually it's very nebulous.
Oh.
But there's a percentage of patients who actually even had their supraclavicular fossa treated.
Interesting.
And the low levels were treated, level 1 and 2. About half the patients got high tangents, okay, which is, we don't really do as much anymore. But when you treat with a high tangent, you're treating level 1, all of level 1 basically, and then about half of level 2.
I see.
So a lot of patients did, in fact, get nodes treated on that trial.
That's interesting.
Yeah, and
didn't know
when I have a
that.
Z11 patient, you really can do it. You could do whole breast if you want.
Yeah.
But I'll frequently treat level 1 and 2. I mean, I'll contour it out and treat it.
I see.
Because of
And
that.
typically, what is your decision? Might as well talk a little bit about when you decide to treat regional lymph nodes with
Yeah,
radiation. A little off subject, but
Yeah.
I think it's important.
Yeah, that's it's relatively straightforward. I think with that, you kind of have to look at how you look at the risk categories of breast cancer, which is if you wanted to go broadly, early, intermediate, or low, intermediate, and high. And so high, I would say, are really women who have 3 or more positive nodes, and they're all going to get radiation. I mean,
I
there's
see.
I can't imagine a scenario where they don't, and that's NCCN recommended, et cetera. In the space where there's 1 or 2 positive nodes, it's controversial. There are clinical trials that are looking at what to do with those patients. We don't know. We have a lot of in the non-neoadjuvant setting. This is adjuvant. And we don't really know what to do. There's places that will treat all of those patients. Some patients, we use a risk matrix table to kind of look at risk factors and then see. The Taylor RT trial is right now an ongoing Canadian, in the United States too, multi-center randomized trial looking at patients with an oncotype of lower than 25 or lower with 1 to 3 positive nodes. And it randomizes them to, if in the mastectomy setting, no radiation versus radiation.
Yeah.
So in that space with like 1 to 2 nodes, it's controversial. But for no nodes, we obviously don't treat,
You don't
unless
treat,
it's
yeah.
a T3 tumor, and there's a lot of risk factors. Then you might want to treat the nodal basins.
Even with the sentinel lymph node is negative?
Yeah, if you had a patient who had, like, say, triple negative metaplastic, large, 8 centimeter tumor, she's
Yeah,
40 years
yeah.
old, that's someone that makes me very nervous, even with sentinel lymph nodes negative, not treating. And, that's something that we probably talk in a tumor board about, but it would be very reasonable to treat a
To
patient
treat
like that.
her.
And she's going to get systemic therapy
Correct.
also.
Yes. The holy grail. Very important.
When I talk about the team, I always say I'm special teams, and then medical oncology is the quarterback.
Oh yes, I always say they leave.
You're all quarterback too, but you're gone already. It's over.
Okay, so
Like Tua.
let's say that we look into the future and we have delineated a select group of patients that do not need to undergo surgery. We've done our trials, whatever the trials are, and we determined that there is a select group of patients that can have surgery safely omitted. How do we maintain a multidisciplinary approach to that decision making?
I think you have to have a system in place where that patient is meeting with all three,
Yes.
potentially even on the same day. And there are certain centers that do that, where you have a multidisciplinary discussion for almost every single patient coming through the door like that. We do it selectively for our patients that are more complex at tumor board. But I think if you're going to say this patient is not going to have surgery and we're going to rely on medical oncology and radiation oncology, like that needs to be like a formal meeting
Yeah.
and discussion of the minds to ensure that the patient is not falling through the cracks and that everyone is on the same page in terms of the plan, because sometimes we send to med-onc and rad-onc and it may be several weeks before the patient sees those specialists, and then you kind
That's
of,
so
you know,
true.
it's not top of mind in terms of what is going on with that patient. So I think making sure that it's all very timely and that they're seeing those specialists almost at the exact same time that you are, if you're going to say that they're non-surgical and you're going to rely on the other specialties to treat.
Yeah, I agree with that. Any other further topics? Or you can talk about, or ideas?
Metastatic disease, you would want to
Yeah,
bring up.
we'll move on to there.
Yeah.
Just I think it is very important though to, like in where I practice, I guess we just rely on a very strong email chain. We don't discuss these patients in tumor board. I think it would be good if we did, but we do try to maintain, like on our email chain is always every specialty represented, surgery, radiation oncology, obviously medical oncology, again, the leader of the team, medical
So
oncology
it's not,
and myself.
not for breast, you don't
This
present
is
that
for
at breast.
cryoablation,
and you
when
wouldn't-
I'm talking about cryo,
It doesn't get presented at the breast, your breast tumor. See, that would
Not
be a great,
usually.
that's
So-
like a
I
But
think
selectively it would.
select, they tend to, if you remember our tumor boards,
I remember
them. They tend to present people after the fact, like things have already mostly happened.
Well,
and then
after
they-
surgical
Yes,
pathology is back. We do the
right.
same, because a lot of the questions that come up are not necessarily surgical. Sometimes they are in
Yeah.
terms of management of the axilla or margins, but most of the time it's what do we do now with this patient
Right.
in terms of med-onc and rad-onc. So it's similar.
Yeah, I think it would be helpful to discuss it in a tumor board setting, because that's the way you can always ensure that everybody's there and engaged and gives their opinion from the different specialties.
I think that'd be a great setting. And then
Yeah.
you can go, pre-op, you can go over the
Agreed.
radiology, see if it's
And
right.
see the path and
Yeah.
all of
See
that.
if
I
it's
think that's
appropriate
the
and-
most the most valuable for me.
Yeah.
Sometimes you read a report and you don't really get a sense of the situation, but when you see the slides and you have the opportunity to query the pathologist
Yes.
in real time,
Yes.
and also look back at the imaging,
Yes.
it just comes across in a different way.
Yeah,
Comes together in a different
I
way.
agree.
Absolutely.
So hopefully, wherever the future takes us, it stays in a multidisciplinary setting for the benefit of these women. Okay, so we'll switch gears, yes, to metastatic breast cancer. I think this will be a very heavy
Sure.
conversation,
Sure.
Reshma.
Yeah.
You're going to talk a lot about this, but there are some questions, and please fill in where you feel it would be benefit to hear. Okay, can you talk a little bit about your approach to metastatic breast cancer? And then if you could also talk about the difference between run-of-the-mill metastasis and then oligometastasis.
Sure. So I think, the big part of the discussion with metastatic disease in the first few visits is really more of an emotional one for the patient, because that understanding that their cancer treatment, if they were treated in the early stage setting and they have all those memories of the chemotherapy they went through, the radiation they went through, they may have some post-surgical issues that they're still dealing with in terms of range of motion or pain or scar tissue. And for many women, it's very traumatic to hear the news that they have an incurable illness. I mean, that's kind of, I think it would be traumatic for anyone.
Yes, yes.
And so I think a lot of the discussions early on are just level setting everyone in terms of what this diagnosis means for you going forward. How is it going to impact your quality of life? What kinds of therapies are available to you? Making sure that they understand that it doesn't, even if you do have to go back on treatment, it isn't the same type of therapy that we're going to give you that you had in the upfront setting, right? So many women get anthracyclines and other chemotherapy drugs that are really tough in the adjuvant setting. And so their main fear is, I have to go back on chemotherapy that's IV, that's going to make me nauseous, that's going to make me lose my hair. And we've made remarkable progress for ER-positive, HER2-negative disease. We have CDK4/6 inhibitors and hormonal therapy. Progression-free survival is over 2 years. You know, so our systemic therapy options for the majority of patients, because remember, 2/3 are hormone receptor positive. I think those discussions are tough in the beginning, but more from an emotional standpoint, as far as just understanding that you're now going to be dealing with this. There's no end to your therapy. So that's a lot of it in the beginning, and then developing a plan that's tailored to their specific cancer going forward is the bulk of the discussions and follow-up visits. For the scenario that you brought up, the oligometastatic patient, that I think is really very individual to the characteristics of that tumor, right? So we know that there are certain patients that have, for example, with ER-positive disease, isolated bone met as their only site of recurrence. They may be young and without comorbidities, and they have a really great response to first-line systemic therapy. I'm sure Star and Joe will talk a lot about the studies that have looked at the incorporation of some local technique, either surgery or radiation, which have been, you know, somewhat mixed. We had the COMET study that was all tumor types and showed a benefit, and then a more recent NRG study that was more focused in breast cancer didn't show a benefit. I think it just speaks to the need to carefully individualize those local therapy approaches for the patient in front of you based on the hormone receptor status, the HER2 status, what other systemic therapy options are available, and what our expectations are from our systemic therapies.
Do you look at a patient with oligometastasis as easier than a patient that has, or no?
No, in fact, I think they're more challenging in some ways because, you know, in our heart of hearts, we always want to offer the opportunity for therapies that may be potentially curative. And even though we hear stage 4 disease is not curative, anecdotally, we've all had patients that have gone into complete responses on systemic therapy, and or maybe have had one site of oligometastatic disease that has been handled with some local technique, and years later they're still alive and well. And we hope that outcome for all of our patients. So I think as medical oncologists, and even as my colleagues will agree, I'm sure, we always want to not take any therapy or any option that is a more aggressive approach off the table. But at the same time, we have to be realistic. If we're dealing with a triple-negative breast cancer that we were lucky enough to catch early, but it's in the liver, and the patient had initially presented with 5 positive nodes and had a short disease-free interval and now came back with 1 spot in the liver, the chances are that that patient's going to develop further progression. And that's very different than an ER-positive patient who recurred 7 years later and has an isolated bone met, right?
Absolutely.
I don't know how you deal with these patients, and a lot of them tend to be very young. And
it's a hard discussion, right? And so as Star mentioned, you know, in the primary setting, she tends to be the first person that meets with the patient. In the metastatic setting, once the patient gets that biopsy result, they tend to end up circling back with their medical oncologist as the first
yes.
person, and they're scared.
Yes.
And there are a lot of emotions. You walk in the room now with COVID restrictions being lifted. You have 5 people in the room.
Yes.
Everybody has questions. There are concerns about family and other responsibilities, work. There are financial toxicities. These drugs are expensive. So it's an extremely difficult situation.
Yeah.
And the good part is that we have the ability to have a team approach.
Yes.
At our institute, we have amazing nurse navigators, APPs, social workers. I mean, I can't take care of all of those aspects
Yes.
of a patient's care, and that's where I heavily rely on the team.
A team approach is important.
Yeah.
Right. Okay. Can you talk, Star, about? I know that you mostly concentrate on the breast and breast surgery, but maybe surgery of the liver in the oligometastatic setting. Any thoughts on that?
I've had a couple of patients very young present with de novo metastatic disease to the liver. One was triple negative, the other was HER2 positive most recently. And in both of those patients, due to them being extremely young at presentation in their 20s or early 30s, and this was their only site of metastatic disease, we said we're going to give them the benefit of the doubt and gave them neoadjuvant chemotherapy and re-imaged the liver. And the liver looked okay afterward, and those patients went on to ablation of those tumors of the liver and then had surgery with a curative intent.
Yeah.
Both had mastectomies, both had post-mastectomy radiation therapy, and I think if you're going to go for it in a young patient like that, you go all the way with it. And so those patients are both doing really well. One is over 5 years out, the triple negative one, the HER2 positive one's only
amazing.
just over a year out. But you have to offer them cure because there's really no other option for them. These are women that are getting married or just married, have young children, and they're asymptomatic from their systemic disease. It's one site that's incidentally found in the liver. We have cases of bone mets that are incidentally found on imaging, and as the imaging gets better and better, you're going to find these little sites of metastases that you would have previously not known about and treated.
That's true.
And so I think specifically in very young patients that are otherwise healthy with one site of disease, I am comfortable operating, especially if they have a great response to neoadjuvant treatment beforehand.
That makes sense. I'm glad you
and we rely on
that.
interventional radiologists to ablate the liver. These patients have not undergone surgery of the liver, but interventional procedures of the liver to ablate those tumor sites.
I'm glad you talked a little bit about breast surgery in these populations. What is your approach for patients with stage 4 disease and the tumor in the breast is intact, either in the setting that the metastatic disease is doing better, but the surgery, the breast?
So this is a back and forth between the medical. I've seen patients 3 or 4 times back and forth between MedOnc and me until we get to the point where we say, okay, now is the time, or no, you're not going to be a surgical candidate. And I think the principle that I rely very heavily on is first do no harm. Because if I think that I can harm them more than help them with surgery, then I'm going to say no.
Yes.
Because these patients have enough comorbidities to begin with because of the systemic treatment they've been on, that me adding on a comorbidity from surgery where I'm not sure I'm being helpful would be the worst thing in the world.
Yeah.
So I think if I feel that I can help them either in a palliative sense, if they have an ulcerating tumor that's just not responding to therapy, I would be willing to do a toilet mastectomy on that patient.
Yes.
Or if I feel that their disease truly is controlled everywhere else but is progressing in the breast and the patient is on board and wants to give it a shot, then I will. But if the patient's unhealthy and has some significant comorbidities where I feel that even putting them through, a surgery that's an hour and a half to 2 hours with not a horrible recovery may be too much for them, then I would say I don't think it's worthwhile, especially because then we get into the conversation of what to do about the nodes. So a lot of these patients have nodal disease at the outset. And so then do you commit them to, are you going all the way with those patients? Are you going to do an axillary dissection and then treat them with PMRT afterward? Yeah. And if that's the approach you're going to use, is that really going to help them if they have multiple sites of metastatic disease and are kind of not well overall to begin with? So it has to be someone who is healthy otherwise, and that I really feel that I can maximize benefit and minimize risk. I don't want to do anything that's going to put them in a worse shape than they were to begin with.
Is there issue with healing if the patient has metastatic breast cancer, is still on chemotherapy, but the breast side is progressing. Is there an issue with doing surgery
So-
and healing?
A couple of things. So usually not necessarily healing per se, but you do have to halt systemic therapy for
Yes.
about a month prior. So if
month,
there's going to be
okay.
an issue with halting therapy
Yeah.
to do your surgery, then that's a separate issue. Patients usually heal fine
Yeah.
as long as they're not smokers and don't have like
Right.
horrible diabetes with A1Cs that are very elevated. Usually healing is not too big of an issue.
Yeah.
It's more
But
of
they have to stop chemotherapy.
Most
And-
of the time, these treatments can drop your white blood cell count, some can drop your platelet count, so you worry about infection. You don't want a patient to go into surgical procedure with
Yeah.
low counts. In the days when we used to use drugs like Avastin, VEGF inhibitors, which
Yeah.
we don't use in breast cancer anymore,
Right.
wound healing problems,
Yes.
fistulas, things
Yeah.
of that sort were more of an issue, but now
yeah.
it's more of an infection
The
and
other
bleeding
issue,
risk.
and you don't see a lot of that, but the other issue is in these patients that you're doing it for palliative intent because they have an ulcerating tumor.
Yeah.
If there is such a large tumor burden there that you're going to have to remove a significant amount of skin, those patients require somewhat large procedures by plastics to just cover the wound,
yeah.
whether it's a skin
That's
graft
true.
or a local advancement flap.
Yeah.
And so you're getting into a more complex procedure. And so those patients, sometimes we defer to radiation oncology if we really feel that putting them through such a big procedure is also not necessarily in their best interest. So it's definitely a very individualized basis in terms of, what risk they're going to have by undergoing
Yeah.
surgery at that
I
point.
know that I've had a medical oncologist ask me to do breast cryo because it seems like everything else is responding, but the breast tumor is growing and they don't want to stop the chemo.
Yeah, I had a patient exactly like this
Yeah.
that I presented in tumor board last week. She had a HER2 positive tumor, was doing really well on trastuzumab deruxtecan, has liver mets, bone, lung, brain, and in her contralateral breast, she has an ER positive HER2 negative tumor
Yeah.
that developed.
Right.
And it's bothering her. She can feel it, it's
Yeah.
hard,
I
it's
remember that
large,
case.
and it's really bothering her.
Yeah.
And she had a lesion in the left chest wall that was part of her original diagnosis that she responded beautifully to with radiation. So she had the idea that I want something locally
Yeah.
done here.
Yeah.
But the real concern is this woman has HER2 positive disease that's widely metastatic, taking her off systemic
Right.
therapy
Yeah.
for a tumor that's not going to be the ultimate cause of her
Her
demise.
Yeah, her death.
Right.
Yeah, and so these are the patients that they send me that are also not surgical candidates, mostly because they can't hold the chemotherapy, and so they send me to ablate them. And it's not necessarily breast cancer, like they could have colon cancer and doing well on their chemo and they don't want to hold it, and then they develop
Of
a
a new
breast,
breast cancer.
and then I ablate it. It's just, that's,
It's interesting. How long of a procedure is that? And is it
cryo?
is it like one session, or
yeah,
they're
one
coming back for
session.
more?
No, one session. Unless it's really big and I miss part of it, then I bring them back.
What's
to do
your
the
size
rest.
limit?
It really is a matter of tumor size and how close it is to the skin. If it's like a 5 centimeters, but it's like a centimeter from the skin, it's easy. But if it's 5 centimeters and touching the skin, it's harder. So it's really a case by case situation. So I address each case very differently. I'm often asked, what's my size cutoff? I really don't have one. It matters how close it is to the skin.
And in terms of how much like machinery it takes, and how was it to set up a cryotherapy program at MSK?
So cryoablation is being done elsewhere in the body, and that's what I did prior to doing it strictly in the breast. So as long as you have an institution that has a cryoablation machine that they've been doing for whatever, liver, lung, kidney, then it's easy to transfer to the breast. You don't need new equipment. There are some fancy, very boutique, small units that they can put in the office setting. It's not necessary. You can use whatever you have.
And it's not painful.
It's not painful.
What are you giving, lidocaine or marcaine, or
Yeah,
what are you
you're
giving?
giving lidocaine, but the ice ball is actually analgesic, so it's not painful. So you don't need sedation. I do tend to give a little bit of sedation because our bed is really uncomfortable, but the ladies are talking and but they're comfortable. Yeah.
And
So
what complications have you seen, if any?
the biggest one is skin injury. So you can cause like a freezer burn on the skin, which is that's the big end. And the larger the tumor and the closer to the skin is the highest chance of that. So if it happens, usually it clears up with just Silvadene cream, which is what I've done. That's the biggest risk factor. I want to talk a little bit about radiation in the setting of metastatic disease. When do you use
I think
it?
that when you look at metastatic disease, the first thing you have to look at is what is the intent of treatment as far as radiation goes. So is it palliative? And if it's a palliative radiation, so in other words, is there something that's bleeding? Is there a fracture? Is there pain? Pain is the most common reason. Then we treat with a certain fractionation scheme, and that's changed, again, de-escalated, if you may, over the years, which less fractions. Everything's been less fractions with us. In the oligometastatic setting, like we talked about, up until this clinical trial BR002 was presented, the abstract was presented at ASCO, we were really both on, and there's many clinical trials, but on and off trial treating patients who had less than, let's say, 5 oligomets, or some places say 3 oligomets, where you have a potential curative intent, right? You're trying to cure the patient with radiation. And there's also a somewhat theoretical paradigm, I don't know if you're familiar with it, called the abscopal effect. Have you heard of the abscopal? Where if you deliver a high enough dose of radiation, what we would call an ablative dose, it creates an immunological response that's T-cell mediated, where other sites that are not irradiated respond.
Yeah.
So you can cure a patient by treating one. And so this is something that is still being actively explored.
Yeah.
But now that,
we have a trial going on at Sloan for that, actually, with radiation.
Oh, I'm sure. Yeah, there's
PD-L1 inhibitor.
Right. And there's a lot of memorial oligometastatic trials. We had them opened at MCI because we have a relationship with you guys.
Yes.
And and there was so the Sabre Comet trial showed this overall survival benefit, which was kind of unexpected with that trial, but it was a very heterogeneous population with all different, prostate, breast, everything, lung.
Yeah.
And so now really many centers, because of the BR002 data that showed equivalent progression-free survival and overall survival compared to no radiation versus SBRT, so treating all sites with SBRT, many sites have stopped treating in the oligometastatic setting. And that's basically, why is that? That's because the medical oncology treatment is so good in breast.
Yeah.
We don't need it,
Right.
We don't need to treat with radiation. But like Star alluded to, if you have a young patient and you have a solitary site of disease, and you talk about it in a multidisciplinary setting, it's very reasonable to treat. But we don't want to treat people that aren't getting any benefit from it.
Yes, it's so there was this trial done by SADOT. I think it's the one that I use whenever I talk to patients, mostly patients. But they did like 167. It's very retrospective, and again, they took patients that had either surgery or ablation in the oligometastatic setting. And then they looked at how they did compared to patients that didn't have surgery or ablation. Yeah. And there was longer progression-free survival when they did surgery or ablation, but no difference in overall survival. And so at least where I practice at Sloan, we look at it as we're just trying to, the radiation oncologist and the interventional radiologist or interventional oncologist, we're really just trying to help the medical oncologist get the patient to the next chemotherapy, and what we use it as is just buying a little more time on the systemic therapy before you have to switch it again.
But that's clinically meaningful, right?
Yes.
Because our therapies have side effects.
Right.
And again, getting back to the emotional aspects of having stage 4 disease, the hardest thing that someone hears is your cancer's come back. And the second hardest thing is the treatment that we're giving you is no longer working.
No longer working.
And we have to change your therapy. So it becomes like a roller coaster ride emotionally for these patients. And there's always the understanding that you don't know that the next systemic therapy is going to work, and you don't know the next systemic therapy is going to be as well tolerated. You know, when you first start, or at least I did when I first started my practice, and you come out of training, you tend to be very aggressive in offering patients a lot of treatments and thinking that you might be able to change the trajectory if something small pops up on imaging, and then you catch it early and you switch your treatment. And I think with time, you get a sense that sometimes it's better to be a bit judicious in how you dole out these treatments. They're all like bullets in a loaded gun. And you don't want to fire them off and waste them, because you don't know that the next bullet is going to be effective, and you don't know what else it could hit.
I love this analogy.
That's how I explain it to patients, because patients often have this feeling when they see slight progression on their scan, oh, that means this isn't working and I have to hurry up and switch to something else. But what they don't necessarily get is that opportunity cost of the quality of life that you're giving up for the next few months, where you may still feel well and not be symptomatic from that progression. But some patients can't tolerate knowing that their scans showed progression, and there's a negative quality of life there because they're, you know, upset about it. So that's where what you do with one person may be different than what you do with the other. And the goal is to do that as a partnership with the patient, and not come in and say, we're doing this and that's it.
I agree. And I think, again, I can only speak for my institution. It's the only place I've worked. It's a very, from my other IR colleagues, I understand that the other disease spaces, there's a lot of competition between the different services. With breast, I can say that there is zero competition. Like we know, because I think we all realize that the chances of these ladies recurring is very high. We're just trying to all work together to get them. So I know that I've done cases where I tried to do radioembolization, it didn't work, or I tried to do ablation, it didn't work. And I'm like, and I reach out to my radiation oncology colleague, and I'm like, can you please try to help me with this? Because so they try to radiate. Or I know that recently there was a patient that had 4 lung nodules on one side and 3 in the other, and I didn't understand the entire reasoning, but the medical oncologist didn't want to start a systemic therapy, and she's brilliant, so I trust whatever she said. But so in that case, the radiation oncologist and myself, we worked together. I bleeded what I thought I could safely do, and the radiation oncologist radiated
you were
the
welding.
rest.
You guys were welding.
Yeah,
you were spot welding.
They did the rest, and the medical oncologist was grateful, and she held off on the medication. I'm not sure of her reasoning, but
maybe
she's
she
brilliant.
was worried about the side effects of the whatever treatment. There was some comorbid condition the patient had that you were worried that you might not be able to tolerate that treatment. And again, it's not just about quantity, it's quality of life, right? Quality of life is paramount in metastatic disease.
So it's a very collegial relationship, and we just all, there's like no ego, we're all just trying to help.
It's because our outcome's so good. I think so. The outcome is just, we have this approach and it works for most.
Yes. So, I mean, sometimes I think the outcome is terrible. These women, a lot of them do, their stories are so sad, but when it does work, it's really a wonderful thing. But yes, the collaboration, I think, is what makes it better for the patients ultimately. Absolutely. Between the different specialties. Let's see. I wanted to talk to you a little bit. I know that MCI does a lot of radioembolization. Can you talk to me a little bit about when you decide to send a patient for radioembolization?
Okay, I thought you were going to ask me a question about radioembolization.
No, when do you decide to send a patient for it?
You know, I think we in breast cancer probably underutilize radioembolization. Just as Joe mentioned, our systemic therapies tend to be pretty good, and many patients respond well for many years. But there are situations where the liver is not responding, but systemic disease is under control, or you have a patient who's blowing through treatments. So I think it's something that tends to be held in reserve for longer than it should in certain scenarios. But sometimes I think it's appropriate because our systemic therapies, especially when you look at subtypes like HER2-positive breast cancer, where our first, second, and third line options afford, good disease control. I think the systemic therapy is kind of used for a longer period of time before we get to the point where we're considering radioembolization. But in my practice, I can tell you I've referred several patients, especially who have progression in the liver as an isolated area and are controlled elsewhere systemically. And again, to your point earlier, just a multidisciplinary approach and recognizing if a patient has limited systemic therapy options but has a good performance status and is still desiring additional treatment, it's another tool in the toolbox.
Yeah.
At MCI also, those cases usually go to the GI tumor board. And
I see.
Yeah, and they talk about the options and it gets agreed upon.
I see. I find dealing with diffuse liver disease difficult, and especially when I know that the patient is progressing in the liver, everything else is controlled, or they don't have any extrahepatic disease, and the patients, though, I find it difficult to do radioembolization on a lot of women where I know that I need to deliver a dose throughout the whole liver, because I find that these patients, a lot of times, I control the liver disease, but they end up in liver failure.
Yeah.
Because you're treating both the tumor and the normal parenchyma, and I find that usually it's the women I've seen it's more in the chronic setting. And I think that is due to the fact that their liver parenchyma, though it looks normal and even their liver function tests are actually fine, they've actually already gotten quite a beating from the systemic therapy. And so I find that a lot of women, although I take care of their tumor, they end up with chronic liver disease.
Yeah, I mean,
what do
our
you think about
systemic
that?
therapies, I think many of them are metabolized through the liver. The overall survival for these patients is extending as our therapies are getting better.
Yeah.
So
Yep.
in a way, obviously that's a good thing, but the flip side of that is they have more time to develop other issues. Like, for example, women who have HER2-positive disease who do very well but then relapse in the brain.
Yeah.
We're seeing a lot of that. It's actually a testament to the success that we've had in our treatments,
That's true.
that they've lived long enough to develop brain metastases. But obviously developing brain mets or progression in the liver is not a good thing. So I do think that there has to be maybe a better algorithm or
Yes,
understanding
I
of how
agree.
we can thoughtfully incorporate some of these local therapy
Yeah.
techniques.
For my approach, if I'm being asked to do radioembolization, if I cannot be selective, like really concentrating most of the radioembolics towards the tumor and sparing a lot of relatively a lot of normal parenchyma, I don't do that case, because I've seen it now many times over that I just push these ladies into liver failure. So I take these cases very seriously, and I understand that when they're coming to me, a lot of stuff has been exhausted and tried, but if I know that the liver has already undergone an insult just because of the systemic, so if I see that I cannot treat these, being very selective, sometimes I have to use several little branches in order to deliver, and that's fine, I'll take the time and do that. But if I have to deliver a low bar dose, like putting the radioembolic throughout the whole liver, I try not to do those cases. But more is needed to know how we can do this technique safely in this population.
Do you do sequential treatments where split courses? Do you do a lot of those?
Yes. So, I mean, sequential already, we do one side, the right side or the left side first, and then do the other side.
Yeah,
and
exactly.
typically I wait. So with colon cancer, which is the first tumor that tried radioembolization, they usually wait like a month between treatments.
Right.
With breast, a lot of times I even wait up to 2 months or even 3 months between treatments because I need to know where that liver function tests, which direction they're going.
Wow.
And if and even if the liver function, before I decide to do the treatment at all, if the liver function tests are even a little bit bad, like I'm talking about like the T-billy is totally normal, but the AST and LT are a little bumped, I think very hard about doing that case because to me, the fact that the LFTs are a little bit abnormal is already trying to tell me this patient is probably not going to do well in the long run. So when I look at these cases, I try to be very judicial, again, deciding to do the case, and again, very, like you're saying, sequential. So I might do one part, see how the
Right.
patient does, and then do the rest.
It's very interesting. So you will wait a longer interval with breast cancer patients because you're concerned about the systemic therapy affecting their liver function
Yes.
more so than a colon cancer patient's systemic therapy.
Yes, my understanding is again where I train, we're very we only do, like, I only do breast cancer patients. I don't do at all colon or CCs. I only do breast. What I understand from my colon cancer colleagues is that there is fewer systemic options for colon cancer than there is breast. So they're trying to save like the 3 options they have, so they don't have, their liver isn't as exposed to so much systemic
They tend
therapy.
to, I mean, it's been a long time since I've done GI, but like if they start with Folfox and Avastin or Folfiri and Avastin, then they're incorporating radioembolization earlier on in
Yes.
the disease course, so
Yes.
they haven't had the
Liver's not
opportunity to
speeding
be exposed to as much.
Right.
Whereas in all of these presentations, if you hear any of these case reports of the patient that got Y90, you see all of their systemic therapies, right?
Right.
And in breast cancer, we have a lot because
Yes.
most of them have gone through endocrine therapy, CDK inhibitors,
Yes.
targeted treatments,
Right.
3 or 4 lines of chemo in the metastatic setting, so they're kind of beat up.
Right.
And then also, what else comes into play is the logistics of it, right? So having to hold the treatment, get the authorization, give the therapy, then when do you restart systemic? And then again, you have to hold because the next lobe is being treated. And then when you have to interpret the response, because as medical oncologists, we're used to giving a systemic therapy, offering a therapy for like maybe 12 weeks or so, doing a scan and getting a clear idea of, okay, a before and after picture. But now there are other things that can sort of confuse the picture. Are you dealing with necrosis? Are you dealing with post-treatment response in the liver? Did your systemic therapy work? What didn't work? So it becomes a little difficult in terms of the follow-up, unless there's clearly new disease outside the liver, then it makes it easier to know that your systemic therapy didn't work.
I find PET scan most helpful than CT or MR after Y90. And we did publish on that you have a better metabolic, you have a faster, I should say, metabolic response than an anatomic response on CT or MR.
Makes sense.
I find these cases tough when they have diffuse liver disease, how to deal with them. All right, I'm ready to wrap up unless everybody has any other topics. Okay,
Thank
so
you.
just as a closing comment from each of you, what is your hope for the future with regards to breast cancer, and what do you think will get us there?
I think my hope for the future with breast cancer is that we continue with biologically driven therapy, and we're able to tease out the patients who don't need certain therapies.
Yes.
And because they just have such an excellent prognosis, and just continuing down that route, so in the where you have in the future, you can really have biology driven treatment and reduce the amount of uncertainty in the treatment courses.
Yeah. Star.
So my hope for the future is, number one, that we have the results of all of these clinical trials that we talked about today, 10 years down the line, and that there are going to be select groups of patients that really benefit mostly from systemic therapy and not as much from surgery. But getting to a point where we are more similar to something like cervical cancer, where there's actually some sort of preventative either vaccine or treatment ahead of time, other than bilateral prophylactic mastectomy, which is very effective but very aggressive, to prevent breast cancer to begin with, because it is such a common disease and affects so many women, that I think we've gotten so good at detecting early and so good at treating that the survival rates for early stage breast cancer can't get much better than they are. And so the two things that we really need to focus on are prevention, and then as the population continues to age and as our treatments get better and better, we're going to see these women living longer and longer. And so better metastatic disease treatment regimens that really don't have as many side effects, so that you can maximize quality of life in these women as they continue to age and get older and older.
Yeah.
So I'll just end by saying I think, all of us are hoping for the day where we have prevention, like a vaccine of some sort, and curing our patients so that they don't have to deal with this illness. Until that day comes, I think, we've made considerable progress, and just hoping to build on that progress by further peeling back our therapies in the early stage setting. One thing that I think many women in the early stage struggle with is, picking up on recurrences, and how will those be found. I think there's a lot of interesting data with circulating tumor DNA picking up on early recurrences, and the challenge is really understanding how to act on that information, and if we can do anything to change the clinical course for those patients. And then in the metastatic setting, as Star mentioned, improving our novel therapies and personalizing them. I think the word of the day is precision oncology, right? So every breast cancer is not the same, every person is not the same, how they metabolize these drugs. And I'll just make a plug again for clinical trials are the way that we're going to answer all these questions, and diversity in clinical trials, inclusivity, to make sure that the studies that we finally have the results of are really representing the patient that walks through that door.
Yes, that's very good. I agree with all these sentiments, and I think the more that we're able to maximize on each practice's strengths, medical oncology, surgery, radiation oncology, interventional oncology, when we work together, I think we will get to the point that, I'll tell you, my goal is that metastatic breast cancer will have the same survival as early breast cancer, which is 99% with stage 1. And I guess that's my dream. And whether that comes with the route of immunotherapy, trying to turn on the immune system with radiation or cryoablation, which is my area of study, whatever that looks like, a modality that hasn't come up yet, or is it immunotherapy, whatever it is, I really hope we get metastatic breast cancer to the area of early breast cancer. We'll see. And yes, clinical trials, I think that will be the road to get there. All right, thank you, everyone.
Thank you.
Thank you.
It's been
This was
great.
great.
Thank you.